So as Deirdre was talking about earlier, when you go into the hospital, the midwife is going to do an examination. She might do an internal examination. She's going to do a tracing of the baby's heartbeat. She's going to check your blood pressure, and she's going to check your temperature. She's going to tell you where you are in established labour or not. So then your pain relief is going to be discussed with the midwife. So the options are, initially, it might be an injection called pethidine. So pethidine is an injection that can make you feel a small bit sleepy. They'll give you the injection if they're happy that baby's healthy and well, and that you're well, that your baby's heartbeat is doing well. You will be put into bed to sleep because you can feel a bit sleepy afterwards. They tend to give that early in labour rather than later in labour, and sometimes that can make you a little bit sick, so they give you an anti-sickness injection as well. As labour is progressing, the other options you have are Entenox, or the gas and air. You've probably all heard about the gas and air. And this is what the gas and air looks like. So how are you going to use it? Again, it's all back to the breathing. So you're feeling a contraction coming on, and you're going to take a big breath in through the gas and air. So you're going, and then you're going to blow it right out. And again, another one in, and blow it right out again. Couple of breaths of this, and you're going to feel a small bit woozy, but it'll help to ease that pain. In the labour ward, these are all connected to a valve, and you'll hear a click, so you know that you've just got enough. It takes about 30 or 40 seconds for that wooziness to pass, but it gets you through each contraction or each surge. So when you're in the labour ward, you're going to have a midwife with you at all times. So this midwife is going to discuss with you and your birth partner all about your pain relief options, and continuously check in with you to see how you're coping with the contractions or coping with labour. One of your final options would be the epidural. So the epidural is an injection given by an anaesthetist, a doctor called an anaesthetist, into your back, which will numb you from here down. So if you have an epidural, you're going to be staying in bed, and they'll be continuously monitoring the baby's heartbeat. They'll probably put a blood pressure cuff on you, and they're going to give you a drip just to make sure that your blood pressure stays okay. You will have continuous tracing of the baby's heart, and probably a tube into your bladder just to drain the urine.
Now I'd like to talk a little bit about the mechanism of labour. So from 36 weeks on, in first time mums, babies, usually their bottom is tucked here right up under the rib cage in mums, and sometimes you can feel a little bit uncomfortable because there's pressure on your rib cage pushing up into your lungs, and from 36 weeks on, the baby then will start to descend down into the pelvis, and you might feel a little bit of a lightening here, and of course then at that stage the baby is pushing down and pushing on the bladder, so you might find that you're up maybe one or twice, 2 times during the night, and maybe this is a way of preparing you for maybe when you're up during the night with your own baby when the baby is born. So I'll just give you a little look at the pelvis. These are our hip bones here, and this is what the pelvis looks like. So you've got the widest part of the pelvis, which is the pelvic brim, you've got the pelvic cavity, and under here you've got the pelvic outlet. This is the pubic bone that you might hear about. These are the sacral spine, and this is the bone here, your tailbone or the coccyx. This actually moves back in labour. So Susan mentioned earlier as well about positions at home, and it's very important to be what we call upward, forward and open, UFO, because this, when you're moving forward or when you're sitting forward, the capacity of your pelvis can increase up to maybe 25-30% when you're actually upright. So probably the best position to deliver in labour is maybe a squatting position, or sitting upright, or kneeling, or any position that you're comfortable in really. But as you can imagine, if you're lying flat and your pelvis is tilted like this, it is more difficult for the baby to go through the birth canal and go upwards, if you like. So try and remember upward, forward and open, and walking around as much as you can as well. So now, as I said, when you're in labour, baby likes to get into the best position it possibly can, which is called the occipital anterior position, but it's baby's back to mummy's tummy. So babies are very clever at doing this. They do a series of movements to get into this position. So, as I said, with the onset of labour, baby moves deeper and deeper into the pelvis. And as baby is going through the pelvis, you're passing as well, anything, contents in the bowel that would be in there would be expelled as well. So basically, women in labour often have a bowel motion, but everybody has a bowel motion. Movie stars, royalty, the whole lot. Don't worry about it, and we're actually delighted as midwives because you know that the baby is going in the right direction. As I said, baby will do a series of twists and turns, and when you get to fully dilated, baby's head comes just right under the pubic arch. So at this point, you'll have your midwife who's with you the whole time, and the pressure will be strong at this point, and you'll be pushing, you'll have an urge to push. And with the pushing, your midwife might see a little bit of baby's hair and be encouraging, saying, listen, you're doing absolutely fantastic. I can see a lovely head of dark hair there coming through. But then when the pain goes away, the head recedes or goes back again. But at some point, with the contractions and the pain progressing, baby's head comes right onto the pubic arch, and it'll get to a point where it won't go back between contractions. And this is called crowning of the baby's head. So once baby's head is crowned, this is when you're going to feel the most pressure. And like the ball and balloon demo I did earlier, this is where you really listen to your midwife, because you don't want to push the baby out at this stage. You want to breathe the baby out, or just gently push the baby out. So you're just gently, as I said, pushing or breathing the baby out. So baby's head comes out under the pubic arch, and baby's head is born. And of course, this is a very exciting time now for mum. It's hard work, but you know you're going to see your baby very, very soon. Baby then will turn his or her head to either side of mum's thigh. So it's called external rotation of baby's head. And this is followed by internal rotation of baby's shoulders. So the baby aligns himself. So with the next push, you feel baby's head, baby is going to be delivered. So next push, first the anterior shoulder, the first shoulder comes down, followed by the posterior shoulder, and baby is delivered right up onto mummy's tummy. And this is obviously what it's all about. First time you get to see your beautiful baby. Baby would be put directly onto your skin, because skin to skin is very important with baby. Baby's gone through a difficult journey. Baby was happy out, 37-degree temperature, floating that lovely warm amniotic fluid, is now outside with bright lights, voices, action. So baby wants to be in mum's chest, listen to mum's heartbeat again. And of course it reduces baby's stress levels, it regulates baby's temperature, regulates baby's blood sugar. So babies basically will have put a blanket put over them and just close up to mum. So when baby is delivered and put right up onto your tummy, onto your chest, this is what the baby will look like. And you've allowed to see this white stuff here. This is called vernix caseosa, which is actually Latin for varnish, and it's sebum, and it's really rich in oil and very good for baby's skin. So as I said, we don't rub all this off, we just gently pat the baby dry and maybe put a blanket over it. And as I said, an hour of skin to skin is very important at this stage. This also is a very special time if you're thinking of breastfeeding, to breastfeed your baby. As a matter of fact, if you never even put the baby to the breast and left baby alone, baby would manage to climb up and find the breast and start breastfeeding him or herself. Also for partners, skin to skin is very important as well, but obviously in this time we've only a limit of 2 hours in after the delivery of the baby. But again, at home for dads, I would recommend skin to skin. That's baby's chest on your chest, and whether you're watching a football match or doing whatever, it's very important for bonding and for dad to have this special time with baby as well when they're at home. So this is the happy part. We're delighted. We've had our baby up in our chest. And just to say one word as well about the labour ward, which I should have mentioned earlier, all the rooms in the labour ward are individual rooms. So you'll be going into a room in the labour ward, that's your own room with your own bathroom. The lighting can be turned down, and obviously as much as possible we try and make this as natural as possible. If the labour is going well, you'll have your midwife with you and your partner, and you shouldn't really need to see anybody else during the delivery. So just to let you know, the rooms are all individual rooms. If anyone's interested in a water birth, there is one room that has a water birth room. Now in the CMH, the baby won't actually be delivered in the water, but you can stay in the water up to full dilatation. So, okay, back to the baby on your chest. As I said, time to breastfeed, special time with the baby. But we also have this stage, third stage of labour to complete, and that is when the placenta separates from the uterine wall. So with the birth of the anterior shoulder of the baby, mums get an injection of syntocinon into their thigh, and this is to help with the separation of the placenta from the uterine wall and also reduce bleeding. So this is our placenta. Your umbilical cord is still attached to your baby. We kind of like to leave that a little bit longer until it stops pulsating, just to increase the amount of oxygen baby gets, and then it can be clamped and cut either by the partner or by the midwife. And then, as I said, this takes about 15-20 minutes after the injection to release. You see, sometimes you see your tummy rising up, and this lengthening, and the placenta is just delivered out. And it's just checked then by the midwife for completeness. That's the third stage of labour. So this is the final thing that will happen to you up in the labour ward. With babies up in your chest, the nurse is going to check, do you require any stitches? So they just do a little examination. If you need 1 or 2 stitches, they will do that in the labour ward at that time. Sometimes during the delivery that they may need to do what they call an episiotomy, which is a surgical cut, and that'll obviously be sutured up at that stage as well by the doctor or the midwife, but that wouldn't be normal practice. So after that, then you will actually just get a cup of tea and toast, which is probably the nicest tea and toast you'll get, and before you're brought back down to the ward.
As well as an instrumental delivery, you may also end up having a caesarean birth. There are 2 types of caesarean birth. There's one, an emergency, which happens quite fast, can be a little bit scary, people are moving very, very quickly, so just do not be alarmed because the professionals are taking care of you and your baby. The most important thing is that the baby comes out quite soon. In both an elective and emergency caesarean section, there can be an awful lot of people in the room. For instance, there's yourself, mother, there's your partner, there's the anaesthetist who will be either topping up an epidural if you had an epidural, or either inserting the epidural. There is the midwife, who's the midwife that may not have been with you in labour, maybe the surgical midwife who's in the theatre. There's the obstetrician, there's the registrar who helps the obstetrician, there's the scrub nurse, the paediatrician, there can be a student midwife, there can be a medical student, and there may also be the porter. So as you can see, there are an awful lot of people in that room. So the most important thing is that you relax. Your baby will come out very, very quickly, as I said. Your partner won't be there when the epidural is going in or when the surgical wound is being made, but he will be there for the birth, so don't worry about that at all. And the most important thing afterwards is your recovery, that you do look after yourself. You're after having major surgery, so really you do need to be mindful of that. You will have a wound, but don't be afraid because the public health nurses in the community to attend to your wound if that needs be.